So ibrutinib was the first BTK inhibitor approved for the treatment of a B-cell lymphoma, namely a mantle cell lymphoma. Ibrutinib's greatest efficacy and its greatest impact on longevity is really seen in chronic lymphocytic leukemia. So BTK inhibition is a very successful target for the treatment of CLL. So ibrutinib, which is now approved in mantle cell lymphoma, CLL, marginal zone lymphoma, and Waldenstrom's macroglobulinemia, is what I consider to be the first generation BTK inhibitor. And what's important about its mechanism is that it covalently modifies the cysteine at position 481, which leads to inhibition of the BTK enzyme. Now, the second generation BTK inhibitors, in my opinion, include acalabrutinib and zanubrutinib, both of which are also covalent inhibitors and require binding to the cysteine at position 481. As such, all three of these BTK inhibitors working identically actually are expected to have identical efficacy, but also the resistance to one of them will also indicate resistance to the other two. Now, the second generation inhibitors, acalabrutinib and zanubrutinib, do have better specificity, and with fewer off-target effects, their adverse event profiles are much cleaner than what we see with ibrutinib. What I consider to be the third generation BTK inhibitors include LOXO-305, becabrutinib, and ARQ-531. These actually are reversible inhibitors that are able to actually block the BTK enzyme without actually covalently binding to the enzyme. So whereas we see the resistance develop in a significant number of CLL patients due to the mutation of that cysteine to a serine, and therefore the loss of the ability of the covalent BTK inhibitors to bind to that cysteine, with the three reversible BTK inhibitors, they actually don't require the cysteine to be there. So even in the presence of a cysteine serine mutant, they still will show efficacy. So these third generation BTK inhibitors are really currently in phase 2 and phase 3 studies, and will hopefully represent the next step in the use of BTK inhibitors in CLL. They do afford, because their area under the curve is really 7 days a week, 24 hours a day, they really do have to have excellent specificity in order to limit the side effects. And the preliminary data seen thus far does really suggest that the tolerability of these agents is excellent as well. So those agents will certainly be entering phase 3 studies, and hopefully they will actually show that those patients who do progress on ibrutinib, acalabrutinib, and zanubrutinib, due to the cysteine 41 serine mutation, at least for those patients, we have an option that will either prevent the development of resistance or at least enable us to continue treatment with BTK inhibitors, because this will be able to overcome that resistance mechanism.